Welcome to episode 12 of the Pro PA podcast. I'm your host, Prof G, and today we're diving into bacterial pneumonia, the first episode in our pneumonia series. We'll start with a quick overview of pneumonia, the difference between typical versus atypical pneumonia, and community-acquired pneumonia versus hospital-acquired pneumonia. Then, we'll break down key bacteria and their buzzwords to help you ace your exams and clinical rotations. It's a little hard to be brief when it comes to pneumonia because there's just so much information to cover, but we'll try our best to stick to the most high-yield information. Let's get started. So first off, let's look at the kinder patho. What is pneumonia? Pneumonia is an infection of the lung parenchyma. The parenchyma is the lung tissue itself down to the alveolar area, and it causes inflammation and consolidation in these alveolar pockets. It occurs when pathogens bypass the body's natural defenses, such as the mucociliary escalator, which is one of my favorite terms, by the way, and the immune cells within the alveoli. The result? Impaired gas exchange leading to symptoms like fever, cough, and shortness of breath. So, who gets pneumonia? Pneumonia can occur in anyone at any age, but we do have some high-risk populations to discuss. Elderly patients. Anyone over the age of 65 is considered high risk for pneumonia. Also, individuals with chronic diseases like COPD, heart failure, or diabetes are also at higher risk. As always, immunocompromised patients, including those with HIV and on chemotherapy, they are definitely high-risk populations. Also, smokers and alcoholics, due to impaired mucociliary clearance, are also high-risk patients. So let's look at an overview of one of the most important topics in pneumonia, typical pneumonia versus atypical pneumonia. Now, atypical pneumonia is a pneumonia that causes consolidation. It's what we think of as the classic community-acquired pneumonia. So usually caused by bacterial pathogens like Streptococcus pneumoniae or strep pneumo and Haemophilus influenza or H flu. Symptoms include sudden onset of high fever, chills, productive cough, and this productive cough is usually with the purulent sputum. They also tend to have some pleuritic type chest pain and some associated dyspnea. The physical exam findings for this, since it is more like a consolidation or a specific area of infection, we will tend to hear crackles or rales and also signs of that consolidation, including physical exam findings positive for egophony and dullness to percussion. We might also see some whispered petroliloquy and some other physical exam findings related to consolidation. Now let's look at atypical pneumonia. Atypical are usually caused by pathogens, often like intracellular bacteria or viruses such as Mycoplasma pneumoniae, Legionella, or Chlamydia pneumoniae. And the symptoms are much different than the typical pneumonia in that they are more gradual, usually have this gradual onset of a dry cough instead of productive, with a low-grade fever, some headache and myalgias, and we see more systemic symptoms like fatigue and even GI symptoms. On physical exam, it's much less key than the typical pneumonia because really all we hear are some scattered crackles without clear consolidation. Now let's look at the community-acquired pneumonia versus the hospital-acquired pneumonia. Now, the name itself is going to clue us in to what type of pneumonia it is. The community-acquired pneumonia is going to be acquired in the community outside of the hospital or within 48 hours of admission to the hospital. Common community-acquired pneumonia pathogens include strep pneumoniae, which is the most common cause of community-acquired pneumonia. We also see Haemophilus influenza, often in COPD patients. We see Mycoplasma pneumoniae, which is an atypical type of pneumonia and usually found in young, healthy adults. We also call Mycoplasma a walking pneumonia. And there's another called Legionella, which we discussed earlier. It's associated with outbreaks like contaminated water or air conditioning systems. So as you can see, community-acquired pneumonia can be both typical and atypical. Now, hospital acquired pneumonia develops 48 hours or more after a hospital admission. And as we know, the hospital setting has a completely different set of bacteria and pathogens floating around. And so the hospital acquired pneumonia tends to be a little more notoriously difficult to treat, and it includes a different subset of pathogens. These pathogens include Pseudomonas, which is associated with ventilators and also immunocompromised patients. We also have Staph aureus, including MRSA. These are often seen in ICU patients or in post-viral pneumonias. We also have Klebsiella pneumonia, which is associated with alcohol use and or aspiration pneumonia. So Klebsiella can be either community acquired or hospital acquired. So, how do we work up a patient with pneumonia? Well, the diagnosis involves obviously a good, thorough clinical assessment. And this assessment is not only going to include the history and a thorough physical exam, it's also going to include imaging and sometimes microbiologic testing. So, as with most pulmonary conditions, a chest x ray is going to be one of the first things that we do, especially when we have signs or symptoms of a lobar consolidation. So on this chest x-ray, we want to look for that type of consolidation. Consolidation is going to appear as white or patchy on a chest x-ray. And a consolidation or in one lobe or area of the lung is going to lead more towards a typical type of pathogen, with strep pneumo being the most common. If we see kind of this diffuse patchy infiltrate, either unilateral or bilateral, this is more consistent with an atypical type of pneumonia. We can also do sputum cultures. This won't help us in the immediate setting, like in the emergency room, but if we do have to admit a patient or maybe we send a patient home with outpatient management and they don't improve, the sputum culture is going to help us identify the specific cause bacteria, which is really important in severe cases. We can also do blood cultures, especially in the hospitalized patients, to look for sepsis. Now, management. First, let's talk about the outpatient management for uncomplicated pneumonias. The first line treatment, of course, we're going to talk about antibiotics because we're talking about bacterial pneumonia today. The first line treatment for outpatient community acquired pneumonia is going to be either amoxicillin or doxycycline. Usually go with amoxicillin first. For the atypical type pneumonias, if we have that type of presentation, we're thinking more of a mycoplasma, we do want to add azithromycin, and this will help for atypical pathogens. Now, for inpatient community-acquired pneumonia, we're going to do a combination therapy. We usually do some sort of beta-lactam, usually like ceftriaxone, plus a macrolide like azithromycin, or we can choose to do a monotherapy with a respiratory fluoroquinolone like levofloxacin. Hospital-acquired pneumonia or ventilator-associated pneumonia is going to require more broad spectrum antibiotics. Remember, we have a lot more pathogens that on our plate that could be causing the pneumonia in a hospital setting. So we definitely want to cover for MRSA, which would include vancomycin, and Pseudomonas, which we usually give like a piperacillin tazobactam. Now, some quick clinical pearls. Always distinguish between typical and atypical symptoms. We might not always be able to tell specifically whether it is typical or atypical, but if you're in doubt, make sure that you have coverage within your antibiotics to cover whatever type of pneumonia you think it could be. Also, for hospitalized patients, time of onset before or after 48 hours is going to determine whether the pneumonia is community acquired or hospital acquired. For hospital-acquired pneumonia, you're going to cover for Pseudomonas and MRSA until the cultures prove otherwise. All right, now I have a quick section on the buzzwords, and this is also kind of a quick refresher on the different bacterial pathogens and some of the buzzwords that you might see in vignettes that'll lead you to the right pathogen. All right, so the first one I have is Streptococcus pneumoniae or strep pneumo. Remember, this is the most common cause of community-acquired pneumonia, so you will see this on standardized testing, and you will see it out in the real world too. The buzzwords for strep pneumo are rust-colored sputum. They also will mention a presentation of a typical pneumonia, so lobar consolidation, and we can often see it in elderly and post-splenectomy patients. All right, let's look at Haemophilus influenza next. Some of the buzzwords for Haemophilus influenza or H flu are COPD patients. They tend to get these type of pneumonias. We also see it in smokers, and it can also cause some patchy infiltrates. Now, Mycoplasma pneumoniae to me is one of the most easy ones to recognize in a standardized patient or in a vignette because the buzzwords are pretty clear. It's usually young adults within close quarters, like a college dorm or a military dorm. And they are termed walking pneumonia because usually you get this dry cough, kind of gradual onset, and it can last for a long time, a cough that won't go away. We also see more generalized symptoms as in other atypical type pneumonias. One other rare finding we can see associated with mycoplasma is bullous laryngitis, which are these little blisters that form on the tympanic membrane of the ear, which are thought to be caused by mycoplasma. Now let's look at Legionella. Legionella or Legionnaire's disease has some really specific buzzwords like contaminated water or contaminated AC units. And they usually can also put in vignettes something to do with some sort of GI symptoms or hyponatremia. And we tend to see these in little clustered outbreaks like contaminated AC units at a conference or a meeting. And actually, that's where the name comes from a meeting of the Legionnaires back in the day where they all got this atypical type of pneumonia. Moving on to Klebsiella. Klebsiella, the buzzwords are going to be alcoholics or aspiration. And the type of sputum that these type of patients get is called currant jelly sputum. If you're not sure what a currant jelly is, look it up. It's a red colored jelly, and the sputum really does look like currant jelly. What's another place that you might have heard of currant jelly something or other? Well, if you've thought about intussusception in kiddos, they get currant jelly stools. So don't get those two things confused. Usually, because of the aspiration, the way that patients are positioned, we can see upper lobe involvement with Klebsiella. Now, let's look at Pseudomonas. Pseudomonas, the buzzwords for that are going to be ventilator-associated pneumonia. They usually have kind of a green sputum. And also, patients with cystic fibrosis tend to get pseudomonal infections. So keep that in mind. Last but not least on our buzzwords, we have Staph aureus, including MRSA. The buzzwords for this bacterial infection are going to be a post-viral pneumonia. So say a patient has a flu or some other type of viral pneumonia. Then after they start getting better from the viral, they get a bacterial pneumonia, and a lot of times that will be Staph aureus. It also can cause cavitary-like lesions, similar to like abscesses that we can get on our skin. All right, so now that we went through some of the background on pneumonia, let's do a couple of questions to test our knowledge. So first off, we have a 75-year-old man who presents with fever, productive cough, and pleuritic chest pain, and it's going on for the past 2 days. His sputum is rust-colored, and a chest x-ray shows a lobar consolidation. What is the most likely causative organism? Is it A, Mycoplasma pneumoniae, B, Streptococcus pneumoniae, C, Pseudomonas, or D, Legionella? I'll give you a sec. If you said B, strep pneumoniae, you are right. Remember, it is the most common cause of community-acquired pneumonia, especially in elderly patients, and it causes that rust-colored sputum and lobar consolidation. Question 2, we have a 48-year-old man who develops fever, dyspnea, and productive cough for 3 days after being intubated in the ICU. A chest x-ray shows patchy infiltrates and sputum culture shows Pseudomonas. What is the most appropriate antibiotic regimen? Are we going to use A, amoxicillin clavulanate, B, piperacillin tazobactam, C, azithromycin, or D, ceftriaxone and doxycycline? Take a guess. If you said B, piperacillin tazobactam, you are right. Ventilator-associated pneumonia caused by Pseudomonas requires coverage with anti-pseudomonal beta-lactam antibiotics like piperacillin tazobactam. All right, so I want to thank you for joining me in today's clinical medicine brief. Maybe today's episode wasn't quite as brief as some of the others, but remember, bacterial pneumonia has a lot to it. Remember the key differences between typical versus atypical pneumonia, and always think about the setting. Is it community acquired or hospital acquired? And this is key when choosing antibiotics to treat. This episode is the first in a mini-series on pneumonia. Don't forget to look out for the upcoming episodes where we will tackle viral pneumonia, fungal pneumonia, and HIV-related pneumonia, all within the same high-yield approach to help you master the topic. If you found this episode helpful, hit follow and turn on notifications so you never miss a new episode. Also, if you're able, comment on topics you'd like to see in future episodes. As always, this is the Pro PA podcast, where future pros in medicine are made. I'll see you soon.